Now that we have a consensus on what we are going to be targeting as a temperature, let's discuss one of the major detriments of cooling our patients, shivering. Our body likes to live between 36 and 38 degrees Celsius, and this is done by utilizing thermal input that comes from our peripheral thermal receptors that account for about 20% of that input, and then our central or visceral thermal receptors. If we are below our 36 degrees Celsius, our body's first response is going to be vasoconstrict to try and keep the blood flow to our vital organs and keep us warm. If that does not occur, we'll start to shiver, starting with the peripheral and building until our entire body is shivering. And I'm sure we've all experienced shivering at some point. It's definitely not something comfortable and it's not going to make us happy. But is it really going to lead to worse outcomes in our patients? Let's think back to what we're utilizing targeted temperature management for. We're trying to prevent this secondary brain damage by reducing a metabolic rate. As we shiver, we can see our lactate and waste products increase. Our excitatory neurotransmitters are going to be escalated. We'll have difficulty maintaining that targeted temperature management, and we can see an increase in intracranial pressure, all of which are going to be counteractive to our goal when cooling our patients. So what do we do to monitor? We can utilize a bedside shivering assessment scale, where 0 is where we're all at now, not shivering, hopefully, and 3 being very severe shivering that includes our trunk and many extremities. So what can we do? We'll go through our non-pharm management and then talk about the tools in our toolbox for building a pharmacological regimen. First, we'll want to provide cutaneous counterwarming. This is covering our head, hands, arms, face, and allowing for that airway to be warmed. This is going to target those 20% of peripheral receptors that are part of our thermal regulation. But caution, this is very limited efficacy once we begin to cool below normothermia. The first medication that's in our toolbox is going to be acetaminophen. This is thought to lower our hypothalamic set point, and one of the major pros of utilizing this agent is that it has very minimal safety profile and is widely available for our use. It's also going to provide us with some analgesia and is something that we can schedule and get on board to hopefully prevent shivering before it happens. A con is that there's some controversy on whether it's needed or not, as we're probably going to overcome that antipyretic effect by just cooling our patients in this setting anyways. Buspirone is another agent that's in our toolbox, and this is going to act on our serotonin 1A receptors, lowering that shiver threshold through modulation of serotonin. And when I think of how buspirone is working in this setting, I'm thinking of that balance that we see when we're trying to control seizures. So we see GABA and glutamate on either side. And when we're thinking of shivering, we can think of it in a similar way where we have serotonin and norepinephrine on both sides. So modulating serotonin can help us reduce that threshold and prevent shivering. Again, pros of utilizing this and having it in our toolbox is that there's very limited side effect profile. We can decrease that shivering threshold by utilizing it alone or in combinations with opioids, and it has been found to have an opioid-sparing effect. Overall, the initial literature behind buspirone is quite weak, and it comes from more anesthesiology settings where it was studied in healthy young adults. But it is found to be a vital option for our patients that are undergoing TTM. Magnesium is the next agent that we can get on board to help prevent vasoconstriction and allow for vasodilation. When utilizing it in the setting of TTM, it's been found to decrease the time needed to get to goal temperature and increase the comfort of cooling for our patients. So the major limitation and kind of our rate limiting step is that it can lead to hypotension. And in a patient that just underwent cardiac arrest, this may be detrimental to them. So if it comes to choosing to titrate magnesium to our target level or controlling our hemodynamics, it's an easy choice that this may be one that we can't push too far. Next, we have opioids that will act both on the mu and kappa receptor and affect thermal regulation through that way. the two major medications that we see being utilized is our fentanyl continuous infusion, our imipyridine PRN agents. Fentanyl is going to allow us to have that continuous infusion with that basal kind of control of shivering. And it allows for very fast on and off, but we could see risk for accumulation. And the most of the efficacy behind opioids and shivering comes from the pyridine, and the kappa receptor is thought to be part of that. But what we can then use is utilize pyridine PRN if our patients continue to shiver while on fentanyl. Most of the evidence surrounding opioids is utilizing the pyridine. However, there's caution in the fact that it's hepatically metabolized, and our major side effect that we need to watch for is neurological. So if we are pooling these patients to prevent neurological damage and then giving a medication that could manifest in neurological side effects, is this the best option to get a clear picture of how our patient is recovering? And then again, keeping in mind that it can reduce the seizure threshold, but definitely effective agents that we can utilize in our patients. The next agent is going to be shifting more into our sedative discussion. Dexmedetomidines alpha agonism can lead to vasodilation and is thought to also act as a thermal regulator and provide for a reduction in shivering by 2.4 degrees Celsius. It will also allow us to try to achieve light sedation, and then has that additional mechanism beyond just sedating our patient to control shivering. So we can see bradycardia and hypotension. Propofol is thought to suppress our excitatory neurotransmitters, reduce vasoconstriction, and then will definitely utilize its sedative properties to reduce the rate of shivering. And it can offer sleep sedation if that's something that we need. Our cons, though, is we have that risk for over-sedation, hypotension, and then there's very limited evidence on what dose is needed to reduce shivering when utilizing it for shivering specifically. And finally, if we're exhausted all the tools in our toolbox and our patient is still shivering or at high risk for shivering, our fastest method of stopping shivering is going to be utilizing paralytics and neuromuscular blockade. So as we know, this comes with a handful of cons. It will require us to be deeply sedated, have mechanical ventilation, and make it difficult to assess our neurological status, as well as the fact that neuromuscular blockades have been associated with worse ICU outcomes, including increased length of time on the vent, length of stay, and even mortality. So now that we know what all of our tools are in our toolbox, how can we put together a protocol to hopefully stop shivering before it's happened? Luckily for us, we'll get into that. Let's get to assessment question 3 though. Which of the following agents match with appropriate mechanism of action for anti-shivering? Acetaminophen does not lead to vasodilation. Buspirone does act on our serotonin receptors, and then fentanyl only works on mu receptors, and the pyridine is on both. Now let's talk about our protocols that have been presented to help control shivering. So the first comes from 2010 and the Columbia Protocol. This was an observational study looking at about 200 patients, but accounting for over 1,300 patient days. These patients were all undergoing TTM and started on a baseline regimen, including scheduled acetaminophen, buspirone, magnesium infusion, and then non-pharm mechanisms. They slowly added additional pharmacological agents based on the patient's incidence of shivering, and having the stepwise escalation to deep sedation and fentanyl if unable to control shivering. These patients were undergoing TTM for a variety of reasons, with only about 27% of them being cardiac arrest patients, but they also included elevated ICP and acute brain injury patients. Most patients were undergoing normothermia, and 80% of the patient days evaluated were patients that were at normothermia. They assessed shivering hourly and escalated if the patient scored greater than a 1. Sedation was left up to the provider at baseline with no distinction between what goal sedation was or what agents were being utilized. And then their primary outcome assessed was the number of pharmacological agents that needed to treat or prevent shivering. Overall, they saw a relatively low use of paralytics, with only about 9% of TTM days needing to be paralyzed, with most of that coming from hypothermia groups. And they assessed a few different risk factors that were associated with the need for an increase in pharmacological intervention, including younger age, male gender, and decreased body surface area. Additionally, I want to point out that we see only 2.4% of all patients having to be paralyzed, and that over 18% of our patient population didn't need any additional pharmacological intervention beyond their scheduled regimen. So this is very promising for the fact that we can control for shivering without utilizing paralytics and deep sedation. One of the major limitations of the trial is that most patients were already utilizing propofol as their baseline sedative, and there was no discussion on what the ideal RAS is when cooling patients to a certain degree. So this leaves us with a few questions. Is there any guidance on how we should sedate our patients? And what happens when we're solely looking at cardiac arrest patients? Is there a difference? And in 2022, Hahn and colleagues presented a retrospective observational pre-post study looking at 131 patients, all undergoing TTM for post-cardiac arrest. They utilized a very similar regimen of scheduled acetaminophen, buspirone, continuous magnesium, and then had goals and parameters around sedation, including dexmedetomidine, titrated to a RAS score of -3, with fentanyl utilized for pain management. If the patients shivered, they would have PRN agents available, as well as the availability of cisatracurium to escalate to paralytic. Overall, most of these patients were out of hospital cardiac arrest, had about 17 minutes to achieve full RAS, and their pre-protocol kind of culture highly advised continuous sedation, analgesia, and neuromuscular blockade to prevent and treat shivering. All patients got cooled to 33 degrees Celsius, and they assessed shivering every 30 minutes for 6 hours and then hourly thereafter. Their primary outcome was that incidence of shivering indicated by a positive score on their shivering assessment scale. What they found was that their post-protocol group experienced shivering less, and they were able to reduce the use of paralytics in this patient population. When looking at their medications, I want to point out that only 65% of patients were receiving acetaminophen, and only 73% were receiving buspirone in their post-protocol group. So even with that drift from their protocol, they were able to show positive benefit by utilizing this multimodal approach. And while doing that, they were able to reduce the amount of propofol being utilized as well as midazolam. So I'm taking that as a step in the right direction, and the fact that they may not have needed to deeply sedate most of their patients or less of their patients. And this is also a positive note as they describe targeting a goal RASC of -3 rather than deeply sedating all of their patients across the board. And they were able to see less incidence of shivering while doing that. So how do we manage shivering here? And hopefully coming soon, summer 2023, we will have a nice order panel and order set to utilize this multimodal approach with scheduled Tylenol, buspirone, magnesium, and then having sedatives available with propofol and fentanyl, but targeting that RAS goal of -4 to -5. So my discussion for you and takeaway from the literature that we've presented is that we may not need to sedate our patients to deep sedation in all settings just because we're cooling. My key takeaway and my question is, if we utilize a multimodal shivering approach and we shift towards a more normothermia and change our way of managing shivering, do we need to deeply sedate? And my recommendation is that having a RAS goal that would be patient-specific and not solely deeply sedating our patients due to the fact that they're being cooled.
Any other questions? Thanks everyone on the WebEx. Feedback forms are in the invite if you would like to please fill it out. Have a good afternoon.